السلام عليكم ورحمة الله.
وعليكم السلام ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته.
How are you everybody? Today inshallah we will have a session in the end of the year. I hope 2021 inshallah it will be a good year for all inshallah. Bless all of members of your families.
Inshallah.
Inshallah, Doctor, we all hope that it will be better.
Yeah, yes. We
Thank you very
suffered
much for
all
your time.
in 2020. Thank you. Okay, let's start to save our time. Today is weekend and everyone had some obligations, some parties. We have case today. I think this case will be important nowadays and in the coming exams. We will see why. But anyway, we will start. Anyone who wanted to practice this case? Station 5.
Yes,
Any
Doctor.
victim?
Yes, Miss here.
It's better to one not practicing before. Yes.
خلاص دكتور محيى.
Okay, Dr. Mahi. Mr. John, he is 55 years old, smoker, complaining of shortness of breath 2 weeks ago. His blood pressure 150/80. His heart rate is 70. You are senior house officer in the medical department. Assess the patient and reply his concerns. For me, I saw this case, exact case, nowadays more than 5 or 6. When you are ready, let me know to start the time.
doctor, you will show some picture of the patient or it's only the scenario?
Sorry, doctor, again.
You will show us some picture or only the scenario is sufficient?
This is no picture for it.
Okay.
Okay.
Okay, Dr. Muhammad, we can start.
Okay, go on.
Good morning. I'm Dr. Gannad, Senior House Officer of the Medical Department today. Am I talking to Mr. June and you are 55 years of age?
Yeah, doctor. I am doctor.
Nice to meet you.
Thank you.
It come to my knowledge that you have shortness of breathing. Can you give me more details about that?
Yes, doctor. You know, I am a businessman, and I had multiple companies, many employees under my work. I was fit before I go and come here and there, but nowadays, since around 2 weeks or little bit more, I cannot take my breath well. I don't know what happened, doctor. I seek for medical advice before, but no benefit.
I'm sorry for that, Mr. John. We are here to help you. Can you give me more about this shortness of breathing? It is stationary or it increasing or decreasing with the time?
I think it's increasing by time, doctor.
Any specific time of the day or all the time?
Not related to time.
It is more with exertion or during rest as well?
It's present at rest, but increased more and more with any effort, any less than ordinary effort even.
Do you get up by at night gasping for air?
No.
Do you have any chest pain with this shortness of breathing?
No.
Any cough?
Little bit, doctor.
Any noisy chest?
No.
Any swelling in your legs?
I am not sure.
Do you notice that any racing of your heartbeat?
No, doctor.
Any change in your weight?
No.
Do you notice your temperature rise?
No, I don't think so.
Any sweating by night mostly?
No, doctor.
Any lumps or bumps in your body?
I am not sure, doctor.
Any change in your bowel habit?
Nowadays, no, but before I had some loose motion.
When this happened?
It may be 1 month or 1 month and a half back.
One attack only or many times?
No, I stayed 3 days with loose motions. Too much. I take medicine and now it's controlled.
It was watery at that time?
Yeah.
Do you seek medical advice for this loss of loose motion?
Yes, sure.
What was the diagnosis at that time for this loose motion?
At the time, I admitted in the hospital for 3 days, and the doctor told me that I had COVID. But nowadays, it's okay.
Okay. Do you investigate for this? You take any swab or PCR for this?
Yes, they did a swab during admission.
From your nose?
And yes, and quarantined for 1 week. Okay. Then after that, I stayed at home.
Okay. Any change in your water work?
No.
Any skin rash?
No.
Do you have any past medical history I should be aware of?
I am hypertensive on medication and controlled.
Okay, controlled. Okay. Show me your medication list, Mr. John.
Yeah, I had valsartan 320 milligram once per day and water tablet.
Okay. Any change in the dose recently?
No.
Okay. You told me you are a businessman and you usually you travel abroad. Sorry to ask you, Mr. John, do you have
Yeah.
any long-term intimate relationship?
Yes, doctor. I married.
Okay. Any recent? Sorry to ask you this question. Any casual relationship recently?
No.
Okay. Okay. Any hospital admission other than this loss of motion?
Sorry.
Any hospital admission before other than this loss of motion 1 month back?
No. No, doctor.
Any blood transfusion before?
No.
May I examine you?
Yeah, doctor. Sure.
I will check the pulse. It is like as a outside or no? 70 equal on both sides.
It's 70 equally and regular.
Blood pressure as outside.
Yes, mentioned.
I will check any proximal myopathy.
No proximal myopathy.
Pallor and jaundice in eyes,
Negative.
tongue, and mouth for hygiene, for ulcers, for any.
Negative.
Okay. Any lumps or bumps, lymph nodes in the cervix.
No lymph nodes.
I will auscultate the heart and the chest for any crevitations, fibrosis of the lung like this.
No. Negative.
I will do percussion to find any basal dullness, stony dullness of the lungs.
Okay, great. Negative.
I will palpate the abdomen for any splenomegaly, hepatomegaly, ascites.
Negative.
May I ask you, Mr. John, do you have any abnormal sensation in your legs or hands?
Yeah, doctor, I feel some abnormal sensation in my hands. I noticed that I cannot write well like before on the keyboard.
Do you have any weakness as well, or only abnormal sensation?
You know, doctor, after this COVID attack, I don't feel well like before. Some of my doctors told me you will feel that for some months.
This abnormal sensation in the 3 fingers or all the fingers?
All fingers of my both hands.
It extended to the forearm or below the elbow joint?
I'm not sure, doctor.
Okay, I will check for this sensation, superficial sensation, pain, break sensation, and joint position.
1 minute remaining.
Okay. What is your concern, Mr. John?
I wanted to take my breath, doctor. What happened?
I appreciate your concern, Mr. John. Actually, this new infection, COVID, it affects many parts of the body. One of them is the lungs, and sometimes it can complicated by scarring of the lung. For that, I will run for you some investigations in the form of blood tests, and may I do also X-ray and what is named as CT on the lung to see if there is any lung fibrosis scarring or no. Also, in spite my examination to the heart is normal, but we should also do echo for you to see if the function of the heart is okay or no.
Yes.
Okay. Then we will be another meeting to update you by the finding of these results. Okay.
Okay. Thank you.
Thank you.
So great, Dr. Mohi. But there is point you didn't touch it. We will see. What's your diagnosis?
Mostly this is pneumonitis or lung scarring, but it is early to develop lung scarring. I wanted to ask you, what about the oxygen saturation at rest for him?
Great. This is one point. Okay. Did you think about anything combined disease between infection and some neuro symptoms, dyspnea?
Yes, Guillain-Barré, but he told me
Yes.
COVID.
There is one
But
fox, multiple foxes said it is Guillain-Barré.
yes, but
Why?
usually
Why not Guillain? Why not Guillain-Barré? What's your evidence? It is
it
viral
can,
infection.
yes, it is viral
Duration
infection.
within 3 to 6 weeks. Then the
Yes.
patient had dyspnea, progressive, plus some neuro symptoms. You didn't catch all the neuro symptoms.
Wow. Yes.
It is good to say it's about to talk about fibrosis. It is one of the complication of COVID respiratory symptoms, but it is too early to have like that. If the patient came later, so we can tell this differential diagnosis. But this patient came early. It is 1 month or 1 month and a half after COVID and diarrhea, upper respiratory and diarrhea. Then he had dyspnea, a progressive dyspnea, some neuro symptoms. You didn't ask about all. So it is Guillain-Barré syndrome.
Yes. Yes.
For
But
me, as I mentioned, yes.
he told me I do swab and the PCR and the, I confirm
Yes,
it
so he
COVID.
confirmed it is viral infection. What do you want more?
He said
confirmed.
COVID. He mentioned COVID by name, so he did not say
Yeah.
it is viral only.
Yes, he said COVID. It means it is viral.
Yes.
So he confirmed that it is viral.
Okay.
The first point in our case today, you didn't ask about respiratory symptoms during COVID. It was respiratory or only diarrhea and GIT symptoms. As we know, the Guillain-Barré syndrome come if there is any diarrheal infection or upper respiratory tract infection. Both.
Yes.
Can viral infection can do both. But to be professional, we should ask and rule out or rule in the respiratory symptoms during COVID. In my hospital, I saw 6 patients. They did consultation for them cardiology because they had intractable dyspnea and the progressive. Then we discovered that it is Guillain-Barré syndrome by combined neurology multidisciplinary team. I didn't see patient, he didn't catch his breathing like that. It is actually progressive dyspnea. The patient is dyspneic. He cannot tell you one sentence. He gave you words. And those patients improved by the treatment of Guillain-Barré syndrome. What other symptoms, neuro symptoms, you should ask in history and do in examination? You ask it about abnormal sensation. It is good because they had numbness or tingling or pain, especially in peripheral, arms or feet. Also, they had some degree of paraparesis. He told you that I am weak and I am not good since the COVID situation, but he don't know what is paraparesis. He don't know. You should assess the power during your examination. Then the reflexes usually hypo or absent. So those are the neuro symptoms I should ask in history and do in my examination. You target your brain about full examination searching for any positive finding. But if you did the general examination and then go directly to the neuro, it's okay, full mark. But I think the Guillain-Barré syndrome didn't come in your vision during our discussion.
Yes, I was thinking in COVID and the complications of COVID.
Yes. So, what are the management of Guillain-Barré syndrome?
First, we should confirm this is Guillain-Barré syndrome. Then the treatment is usually symptomatic. Immunoglobulin is the main treatment, and plasmapheresis sometimes needed. And detect any early manifestations of the lung problem. So for functional capacity measurement serially, and if needed respiratory failure, we will at that time will put use mechanical ventilation.
Great. How can you follow the Guillain-Barré syndrome? What is the test you should follow?
Autoantibody.
No,
There is-
follow up by forced vital capacity.
Yes, for vital capacity for the lung. Yes.
Yes. This is the one we monitor the function of the heart. The patient need invasive or non-invasive treatment. And as you mentioned, the immunotherapy is the mandatory treatment for those cases, either by plasmapheresis or IVIG. This is a treatment of choice. And those patients I talk about them, they improved dramatically about after IVIG. We don't have plasmapheresis in my hospital. And also steroid. They take pulse steroid. Beside what you said, Dr. Mohi, we should add rehabilitation. Those patients, they found that rehabilitation for the lungs, and even by walking only, besides the respiratory training through respirometer, the function of the lungs improved too much. So beside treatment, invasive or non-invasive, and follow up by forced vital capacity, we should rehabilitate them to regain their power again. This is about Guillain-Barré syndrome. For memorizing ourselves, for summarizing what we said, Guillain-Barré syndrome, it is a post-viral syndrome, usually come after upper respiratory tract or diarrhea, GIT, viral infection, and symptoms appear within 3 to 6 weeks from infection. Then the patient will have progressive down to up weakness. This weakness may occur in the lower limb only, may catch the respiratory muscles and causing dyspnea. So the cause of the dyspnea here, not the lung issue, but it is the weakness of the respiratory muscles. Beside other neuro symptoms like numbness, tingling, and paraparesis, and reflexes are absent or weak. So I should assess the sensation, I should assess the power and the reflexes. Not full neuro examination, but only I can do 1 or 2 from each point. It's enough. The characteristic of Guillain-Barré syndrome is symmetrical progressive. The patient will tell you, if you ask it about the neuro symptoms, it is symmetrical and start weak and then increased by time. So this is about Guillain-Barré syndrome. Treatment, as we mentioned, non-invasive through plasmapheresis and IVIG. Some trials they give steroid and some not, but the main treatment is plasmapheresis and IVIG. Intubation or not, mechanical ventilation or not, this is according to the vital force capacity, follow-up of the patient. And the rehabilitation programming to the patient, because those patients, even after improvement of the condition, they still had exertional dyspnea and weakness of the body, so they need rehabilitation program. So that's all about Guillain-Barré syndrome. What I said in the beginning, we will face this case many, because and even there is one doctor in UK, Egyptian doctor, if you heard about him, cardiologist, and he had the severest form of Guillain-Barré syndrome because of COVID. So take care of this case. Any questions about this one? Okay, clear for all. So let's go to the other case. I bring this case, the second one, because we wanted to talk about the recent guidelines for these cases in NICE guideline. So, who will be the second victim? Thank you, Dr. Mohd. Any volunteer?
Okay, can I take it?
Who's Dr. Ahmed?
Yes.
Okay,
Okay.
let's play the game.
Okay.
This is also station 5.
Yes.
Inshallah, the next session, next week, it will be station 4. It will be communication. Interesting cases with simple approach like before. Mr. Mark, he is 70 years old. Complaining of vision problem since 1 month. You are senior police officer in the medical department. Talk to the patient and reply his concerns. We will start the case once you ready in 8 minutes.
Dr. Muhammad, sorry, I wanted to ask for Guillain-Barré. Sometimes I saw one patient, he has atrophy and wasting, severe wasting of the lower limb muscles. Yeah, he has lower motor neuron character of the by, and he said this patient diagnosis is Guillain-Barré syndrome. This patient is chronic, and since long time he is the same.
Yes, maybe the disease affects the muscles, become advanced fibrotic and advanced paralysis or weakness. In many cases not catched that it is Guillain-Barré syndrome, neglected. The antibody still in the blood and working like this.
يعني البروجنوزيس بتاع الجليان-باري سندروم انه او الفيت بتاعه مثلا كام في المية يحصل له كذا وكام 30% يحصل كده يعني ولا
I didn't read the figure, but Guillain-Barré syndrome or any disease with antibodies in the blood, the treatment of plasmapheresis and IVIG is dramatic response. Also, I saw one patient with myasthenia gravis crisis. You know, myasthenia gravis is chronic disease. Patients on medication forever or for long life. But during the attack of firing, they received pulse steroid and IVIG, dramatic response. For Guillain-Barré, it is post-viral. So if it's catched early and treated early, I think the effect will be good. We will search for the prognosis. If anyone had any information, share with us.
Yes, doctor, sometimes it can result into chronic wasting sometimes, but mostly it recovers good.
Yes.
And I remember there was one station 4 in the last few nights in which the lady was told that his son developed GB syndrome and he will recover, but unfortunately he didn't recover. So she was very upset that why I was
Yes.
told that the prognosis is good when he can have permanent damage to the nerves. So this can happen. Yes.
Yeah, thank you, doctor.
Doctor, 80% they will recover. 20. 15%. 15
This is
will
question. This is question or information.
information on.
Okay.
80% will usually they are recover, and then 15% with the residual paralysis, and 5% will not improve.
Great.
What are the investigations that we do for GBS practically, other than bookish investigations?
It's a clinical diagnosis. There is no specific test apart from forced vital capacity. No specific another test for it.
What about the nerve conduction studies in this?
Sorry, about what?
Nerve conduction studies, NCA.
I am sorry, I didn't hear you, doctor. There is noisy background.
Nerve
Again, please.
conduction is nerve conduction studies in GBS, NCS.
Narrow conduction study. Nerve conduction study.
Yes. Is it a good investigation to tell in exam, or is it just a bookish thing?
It is not. It is not written for nerve conduction or electromyogram. Not written, mentioned as a tool to diagnose Guillain-Barré syndrome. They didn't mention any test, specific test for this disease. And even if you saw any there is any practice with nerve conduction or even EMG, so it is not as a guideline. If you return back to a nice guideline, you will find the only test is forced vital capacity, and there is another test through respiratory function, negative inspiratory force. Another test, but it is advanced. So even all are through respiratory function. There is no blood test to check for antibodies or something like that.
But
What
we
is
also
about lumbar puncture? Lumbar puncture.
Yes, also all are added investigation. We talk about specific test. The Guillain-Barré syndrome, there is no target specific test.
Okay.
It's a clinical diagnosis by history of the patient and the assessment of the neurosymptoms.
Okay. Thank you, sir. Thanks.
Sorry?
We can start.
Okay, I will mute all because there is some background noise. Then you can start to talk. Okay, let's go.
Hello, I am Dr. Abdel Hamid, one of the doctors in the clinic today. Nice to meet you. Are you Mr. Mark, 70 years old?
Yes, doctor, I am.
I have received a letter from your GP stating that you have problems with your vision. Could you tell me more about this?
Doctor, since 1 month I cannot see well by my left eye.
Yes. And do you have any previous attacks like this before?
No.
No previous. Is it progressive or not?
No, since it happened, it's like before.
And it is continuous. Yeah, it's the same. At the same time, you are now not have the same problem, or it recurs to normal.
It is the same, doctor.
Okay, is your left eye in which part of your vision field?
All my eye, doctor.
Do you have any pain in your eye?
No.
Any headache?
Before I had some headache, but now it's okay.
Headache occur at the same time with the vision problem?
Yes.
What is the character of this headache? Is it throbbing or which character exactly?
All my left side of the head, I had pain.
In the left side only of the head?
Yes.
Do you have any weight changes?
No.
Do you have any weakness in your arms or legs?
Yes, doctor. I had weakness in my right leg.
On your right leg, not the other leg or arms.
My right leg and my right arm.
Right leg and right. Since when?
1 month.
1 month also. Okay, and is this affecting? How is this affecting your daily function and activities and your job?
Yes, doctor. I cannot go to my garden and doing my habits.
I am so sorry for that. What do you do for work?
I am retired, doctor.
And what's your previous occupation? Or
I was a taxi driver.
okay, and now you are on the driver for the taxi or have stopped?
No, stop. I cannot, doctor.
You are not driving now, yes?
Yes.
Okay, do you smoke? Do you smoke?
Yes, doctor.
How many cigarettes for how long?
I had, doctor, like 15 cigarettes since 40 years.
And do you have any problem with your chest? Any cough?
No.
Any coughing blood?
No.
Chest pain?
No.
Could I examine you, please?
Yes, doctor. Sure.
I'd like to examine vital signs pulse. What is the pulse? Regular or irregular?
Pulse is 8% per minute regular.
Okay, I like to the carotid for Bruy auscultation.
Okay, no.
Okay, I like to examine your vision. First of all, visual acuity, snell and sharp if present. If not, your finger.
Okay, normal.
Normal, both eyes.
You ask about vision what?
Vision acuity, visual acuity.
Acuity in the left eye, it is diminuted.
Yes.
You cannot see by the left eye. It is normal in right eye.
Okay. I'd like to examine the extraocular muscle movement. Its shape. Any
Okay, no need. No need.
No need. I'd like to examine by fundus examination, ophthalmoscope.
There is only light perception, and the fundus no need to examine.
Only light perception. Okay, I'd like to make a neurological examination. Tone bar reflexes. Tone. Right and left.
In the upper and lower right.
In the
the power upper and lower right.
Yes.
The tone is 2/5.
Yes.
There is areflexia. Sorry, there is exaggerated reflex.
Yes.
Yeah, okay.
On the right side?
Yes.
Okay. And on the left side?
Normal.
Normal. And what about Babinski?
Upgoing.
Upgoing. Okay. And the sensation? Right and left?
Sensation for pinprick sensation, it is diminished.
Pinprick, only pinprick sensation is diminished?
Yes.
Okay. Do you have any other conditions should I be aware of, Mr. Mark?
Other what?
Medical condition of note?
Yes, I had also, doctor, cannot speak well like before.
Since 1 month also?
Yes.
Okay. What about your control on back passage and your water work?
Now it's okay, doctor.
Any loss of consciousness?
No.
Fainting attack?
No.
No fainting attack or loss of consciousness. Yes?
Yes.
Any problems with test sensation, hearing, choking? Time?
No.
What's your concern, Mr. Mark?
1 minute remaining.
What's your concern?
I wanted to go and enjoy my habits, doctor. You don't have anything. I cannot. What happened?
I appreciate your concern, Mr. Mark. From what you say to me and from your examination, it seems that you have a condition called stroke. It is seems like you have a blockage of one of the blood channels supplying your brain. Therefore, what we need to do now is to admit you and to make urgent urgent imaging of your brain and other blood tests and imaging to confirm our diagnosis and to rule out other diagnosis. And until then, I will give you the result of this test when it come back. Is that okay for you, Mr. Mark?
So you will admit me, doctor?
Yes,
Okay.
I will admit you in order to make an urgent CT for your brain to confirm my diagnosis.
Okay. Thank you.
Thank you.
Okay, great, Dr. Ahmed.
Thank you.
I bring this case not to catch the diagnosis and making the examination. It is a clear case of stroke.
Yes.
But the discussion around this case is the important one.
Yes.
Because there is some recent changes about the something in the management plan. We will see this. So this is a case of stroke.
Yes.
What are the major symptoms of patient with stroke?
Major symptom of patient with stroke, according to its level, but this upper motor neuron lesion together with
Yes, great.
this arthria and
Great.
and the arthrosis effects, and it is clear that he has an upper motor neuron lesion, so it is stroke.
What are the alarming signs to catch that the patient had the stroke?
Alarming sign: weakness more than 60 minutes in one or more limb, and upper cortical function as this arthria. Or also if there is loss of consciousness.
Okay. Okay. What is the time window in patient with a stroke for CT?
For CT
and MRI and for thrombolytic.
For thrombolytic, 4.5 hours. I think these are previous guidelines. I don't know the recent one. For CT, I think and MR, CT first of all within 1 hour or very early. MRI could be done later on, but the most important non-contrast urgent CT immediately. Then thrombolytic therapy if we
Okay. Again, please. CT when?
CT immediately within half hour or 1 hour maximum. And if no hemorrhage or if no hemorrhage, if we exclude hemorrhage, we can proceed to thrombolytic therapy up to 4.5 hours. Previous guidelines.
Okay. MRI?
MRI, we can postpone it if to exclude other diagnoses like MS or something like that, or SO, specific English.
What is the indication for MRI in stroke?
Indication of MRI of stroke if there is no relevant or evident cause by the CT. If I suggest that the other diagnosis as multiple sclerosis, demyelinating, or if there is space occupying lesion and I'd like to delineate it.
Okay. What are the tests you can do to see the cause of stroke?
Test to see the cause of stroke, imaging, CT, MRI. I could do also, but not in this case, I could do a coagulation profile. If the patient is younger, I could do also investigation for antiphospholipid syndrome or high thrombophilia, but not at this age.
Okay.
And for risk factor of at this age, for risk factor hyperlipidemia, hyperglycemia, hypertension should be for thrombotic or ischemic stroke.
Okay, what is the first aid treatment or therapy for patient with stroke?
Clopidogrel plus aspirin. If I exclude hemorrhage by CT, I will give him statin plus aspirin plus clopidogrel as first aid measure. And admission
So
in the
how?
stroke unit.
Yeah. Okay. Okay, let's fight because there is some information are not clear. So the stroke is one of the cases which is very important, as we know in bases. It can come in communication in station 2, station 5, and station 5, and even in clinical stations. Anyone who didn't catch the signs of stroke, it is a big mistake because it is clear signs. The patient will, if you saw the patient for the first look, you can see that he has had stroke. It's one of the spot diagnosis because of the picture of the leg, if he had one leg stroke, or the arm, or when you talk with him, some dysarthria or facial drop. So, for my opinion, stroke one of the spot diagnosis in most of the cases in station 5 or in clinical station. The target of Royal College in stroke, like we had a case before for acute coronary syndrome. The data around acute coronary syndrome changed. So we took the case to discuss about the timing and windows and the different types of acute coronary syndrome and how to manage prognosis and so on. Also here in stroke, the reconstruction of the stroke itself, some changes, very small changes, but there is some difference in the reconstruction itself. So if we talk about what is the test you should do to assess the cause or to know the cause of stroke, we will not do CT or MRI or anything on the brain. What happened on the brain happened. But what is the cause to let this happen? Usually it is a cardiac problem, like atrial fibrillation or lipid profile and dyslipidemia and carotid artery atherosclerosis. This is the most common causes for stroke. So I will do electrocardiogram, ECG, I will do echo and Holter. They put in the guidelines recently, if you do ECG, multiple ECGs, and you didn't find source of any atrial arrhythmia, so we will do Holter for the patient. This is number one. In the guideline, it was present before, but they highlight on it in nice guideline. Holter monitoring. Number two, carotid Doppler, it is present since before, and lipid profile to see any dyslipidemia. And coagulation profile, because it may have hemorrhagic stroke due to coagulation profile is abnormal. This is the test, how to do test to assess for the cause of stroke. So ECG and echo, and if not detected, we will do Holter. Then we will assess the lipid profile, carotid Doppler, and coagulation profile. For the imaging and windows, CT brain, when I choose between CT brain and MRI, and this is the recent one, in acute stroke, I should do CT brain directly once the patient arrived to emergency department, as soon as possible. They wrote as soon as possible. There is no time window. Once you saw the patient and finish the paperwork, do CT brain. And when I do MRI, I will do MRI in chronic stroke, like our patient today, or within 24 hours in cases of TIA. And if the patient is seen within the 24 hours of the acute stroke. we have 3 indication for MRI in patient with stroke. If the patient came with history by the relatives that he had these symptoms around 24 hours, so for us, he passed the window for thrombolytic therapy. So we will proceed for CT or MRI if he came after 24 hours from the symptom. Or for chronic stroke, like our patient today, more than 1 month, or in a case of TIA within the first 24 hours. Those are the indication for MRI in patient with stroke. This is the simple indication. We will not go deeply in the diseases itself. We are talking about the patient came to arrived to ER, and we will manage him. So we talk about CT, we talk about MRI, then we talk about aspirin. Before they give aspirin and clopidogrel as a first aid treatment for the stroke, now it is aspirin only 300 milligram. In cases of TIA and chronic stroke, it is not given to a case of acute stroke. Why? Because he may be hemorrhagic or embolic. So if the patient came to me on ER and I don't know everything about him, I will not give him aspirin until I did CT and rule out hemorrhage. In patient with chronic stroke or TIA, I will give aspirin 300 milligram. Time window for thrombolytic therapy or fibrinolytic therapy, now it is 4.5. Before it was from 3 to 4.5. Now it is up to 4.5, and in certain situation can be exceeded to 6 hours. But the ideal is 4.5. Before we assess the TIA by scoring A, B, C, D, E. But now this scoring is obsolete from the guideline. So those are the new data I would like to share it with you, because as I mentioned, to catch a stroke patient and do examination and history, I think it is easy. Training, it will be easy. But the information and clear information should be known for us. Plus this, what we are talking, don't forget the routine lab, the routine studies we should do. There is workup, complete workup for patient with stroke. So I may be asked in from the examiner about workup, so I can divide them in the blood imaging and laboratory and to assess the cause, what is the cause. Or he may ask me directly about the recent events, what is the cause of, how do you assess the cause of stroke. For laboratory, we can do blood sugar, we can do complete blood count, biochemistry, biomarkers, cardiac biomarkers. This is tricky point here also in cardiac biomarkers, because the patient who was younger patient, he came with stroke. Cardiac biomarker will be elevated in stroke generally, and especially in patient receiving illicit drugs and cocaine by name. So if you remember, we said before, illicit drug is one of the famous issues nowadays. It can come in anything, in any disease, and in any station. So cardiac biomarker increased in any patient with stroke, and a younger patient who received illicit drugs, cocaine, it is the one claims that increased cardiac biomarker, especially troponin. And so toxicology, it is one of the laboratory tests for patients with stroke to rule out any illicit drugs he received. This is for laboratory. For imaging, all of us know the imaging test, CT, as we mentioned, and there is also MRI and carotid Doppler, and even nowadays for the tertiary centers, there is a conventional angiogram, cerebral angiogram. There is a window also for this. If the patient had received fibrinolytic therapy within the window and failed, so the patient will go for cerebral angiogram. This is in the hospital who had stroke unit. So if I had in the hospital stroke unit and there is angiogram available, what is the preferred for the patient to give thrombolytic or fibrinolytic therapy or direct to angiogram? For the stroke unit, the patient came in window 4.5. Fibrinolytic therapy is the best. If failed, so we will shift him for angiogram, not like coronary artery disease. Patient with STEMI, if they came within window, it is the best to do PCI, primary PCI. But in a stroke, within the window, the best is fibrinolytic therapy. I asked also one question: what is the alarming sign from which you can know this patient had a stroke or no? You didn't examine the patient or talk to him. These include the dysarthria, facial drop, and arm drop or shoulder drop. This is the alarming sign for acute stroke to see he is in stroke or not. I finished the data I would like to share with you. Anyone had any question? He can share with us. By the way, the site of stroke you will find in some books like OSCT. They talk about many pages about the site of stroke. Don't bother yourself about this too much information. No one asked this question at all before. So the site, this is for our information. If you wanted to build up your information, it's okay, good. But for the exam, forget this.
Doctor, this 4.5 hour is window period for fibrinolytic therapy?
Yes, 4.5.
Okay.
Before it was 3 to 4.5. I don't know what is the change, and up to 4.5, but they remove 3 from the guideline.
Okay, thank you.
Welcome, doctor. The data is clear?
Yes.
Okay.
Doctor, I have one reservation about the first case.
Yes, Dr. Tanzil.
I got this case in station 2, GB syndrome. I got it in station 2. But
Yes.
mostly it comes like with weakness of legs. So this is shortness of breath is very unusual presentation. Like we did a case yesterday with weight gain and obstructive sleep apnea.
No, the shortness of breath and Guillain-Barré syndrome, it is a common symptom.
So how can we? So should we include GB syndrome in the DD of shortness of breath? Because normally we think about cardiac causes, respiratory causes.
It is already present in the cases of dyspnea, Guillain-Barré syndrome, ascending issue affecting the respiratory muscles. Then the patient will have this problem.
Okay. Anyways, it was a good brainstorming that GB syndrome can present like shortness of breath.
And why it is mentioned in the management, the forced vital capacity, the respiratory function test, because it is the leading cause of admission. Respiratory failure. 25% of the cases develop respiratory failure, and the cause of this.
Okay, doctor. Thank you very much.
Okay, thank you all my friends, and Happy New Year for all. Inshallah,
yes,
I will announce for the next session. We want to make this practice every now and then. My advice to me before you, we will note this practice and discussion not for the exam, but for our clinical improvement, to gain the benefit to us and to the patient. So keep in your mind that this information we are talking and discussion practicing, it is not for MRCP basis exam. It's for us. And by the way, it will help us in the exam.
Thank you.